Okay, welcome. Let's jump right into this deep dive.
Yeah, sounds good.
Today, we're looking at Respiratory Syncytial Virus, RSV.
Mm-hmm. A really common but sometimes serious virus.
And we're using some very focused, sort of high-yield revision notes as our source.
Right. The aim is to pull out the absolute must-knows from these.
Exactly. Distill it down, make it stick for you. So, first off, what actually is RSV?
Well, the notes define it as a common respiratory virus. It often causes just mild cold symptoms in, say, us.
But it's a major cause of more severe illness in young children.
Critically, yes,
Yeah.
especially infants and anyone immunocompromised. It's a paramyxovirus. That's its category.
Okay, paramyxovirus. Got it.
And a key thing to remember, it's highly contagious, spreads really easily through droplets, coughs and sneezes.
Surfaces, too.
And surfaces, yes. That contagiousness is central to why it's so common, particularly like in winter.
Right. Which leads us straight to risk factors. Who's most vulnerable?
The notes are clear here. Infants are top of the list, particularly premature infants, very high risk.
Okay. Any others?
Yeah, definitely. Smoke exposure is a big one. Attending daycare or nursery again, that easy spread.
Makes sense.
Also having a weakened immune system or underlying heart or lung problems. These are the groups you worry about most.
So let's get into the pathophysiology. How does it actually, cause the problems?
This is really key. It specifically attacks the bronchioles.
The really small airways.
Exactly, the smallest ones. It replicates in those cells, causing quite a bit of inflammation and swelling.
Okay.
And it does something quite specific. It causes infected cells to fuse together. They form these clumps called syncytia.
Syncytia.
And plus, it triggers the production of loads of thick mucus. So you've got inflammation, swelling, fused cells, and mucus all clogging up those tiny airways.
Ah, okay, so that physical blockage is why breathing gets so difficult,
Precisely, that's the mechanism.
which explains the clinical features. So, mild cold in older people, but what about infants? What are the signs we need to look for?
Well, you get the typical cough, runny nose, maybe a fever, but the crucial things in infants and young kids are the respiratory signs. Wheezing is common, and obvious difficulty breathing.
And there are more severe signs, too. Red flags.
Absolutely. For revision, you need to know these cold, rapid breathing tachypnea. Retractions, that's where the chest wall gets sucked in.
Yeah, you can see them working hard to breathe.
Exactly. Bluish skin, cyanosis, showing poor oxygenation, and lethargy being really floppy or unresponsive. Those are urgent signs.
Okay, really important.
Uh-huh.
What about timing and what else it could be? Differentials.
Seasonality is strong in the UK. It's mainly a winter thing. For differentials, think other common respiratory viruses.
Like flu.
Influenza, yes. Rhinoviruses, the common cold ones. Adenovirus, parainfluenza, they can all look similar initially.
So you often need more than just the clinical picture.
Often, yes. Clinical suspicion is high in the right context, like an infant with bronchiolitis in winter, but tests help confirm.
Which brings us to investigations. What do the notes say here?
Clinical diagnosis is common, but lab tests are available, rapid antigen tests, or the more sensitive PCR tests on respiratory samples, like a nasal swab.
PCR, okay. Chest x-ray?
Sometimes it can help assess severity, look for things like pneumonia, or rule out other issues, but not always needed for diagnosis itself.
Right. Now, management. This feels like a really high-yield point from the notes.
Definitely. The absolute key takeaway is that there's no specific antiviral treatment routinely used for RSV.
So it's all supportive care.
Overwhelmingly, yes. That's the cornerstone, keeping the child hydrated, managing any fever, using saline nose drops to help clear things out a bit,
And just watching them closely.
close monitoring of their breathing, their oxygen levels. Severe cases mean hospital.
And in hospital.
That's where they might get supplemental oxygen, maybe fluids if they can't drink enough. And in the most severe cases, respiratory support, potentially even ventilation. But it's all supportive.
Got it. Supportive care only. What about the prognosis? Generally okay.
For most healthy children, yes. They usually get better within, say, 1 to 2 weeks. Prognosis is generally good.
But there's a but.
There is. The so what, as you said earlier. In those vulnerable groups, the prem babies, kids with underlying conditions, complications can be serious.
Okay. What sort of complications are we talking about?
Well, bronchiolitis itself is often caused by RSV, but severe bronchiolitis is the complication in a way. Then there's progression to pneumonia, developing respiratory failure.
Needing that ventilation support.
Exactly. And it can trigger wheezing later in life or worsen asthma. In those high-risk groups, these complications can sadly be life-threatening.
Right. A crucial link to make for a revision vulnerable group. Potential for severe outcome. Okay, so let's quickly recap the essentials for revision. We've got RSV, a common, highly contagious paramyxovirus.
Hits infants and vulnerable groups hardest. Risk factors like prematurity, smoke exposure are key.
Pathophysiology.
Hmm.
Targets bronchioles, causes inflammation, syncytia, lots of mucus leading to obstruction.
Clinical signs range from mild cold to severe respiratory distress. Watch for tachypnea, retractions, cyanosis in babies.
Diagnosis often clinical, but PCR available. Differentials include flu, other cold viruses, typically winter season.
Management is purely supportive hydration, oxygen if needed, no specific antivirals.
Prognosis good for most, but serious complications like pneumonia and respiratory failure are real risks in vulnerable infants.
So, a final thought for you to take away and consider for your revision. Given that mechanism, the syncytia, the mucus physically blocking those tiny airways, and the signs like retractions showing the effort of breathing, what specific supportive measures are most directly aimed at relieving that obstruction and improving gas exchange in a severely ill infant?
That's a great point to ponder. It really connects the why with the what's.
Yeah, exactly.
And if you want to dig deeper or test yourself on this, definitely check out PassTheMSRA.com.
Yeah, and FreeMSRA.com also has some excellent resources. They're really useful for this kind of targeted revision.
Great recommendations. Thanks for joining us for this deep dive.
My pleasure. Good luck with the revision.